think it's sort of similar outside of US. The majority of people living with HIV are above the age of 50 and older. So they start, kind of their providers, and they themselves start sort of facing a lot of issues related to getting older, such as more cardiovascular disease, diabetes, bone health, nutrition is obviously different, and the way we handle other infections and stress is very different, kind of in that more mature age group. So I'm really excited that we're joined today by Dr. Monica Gandhi, who will tell us about the COMPASS geriatric HIV program that's based in San Francisco General Hospital, and we'll talk about kind of the funding and programmatic sustainability and lessons learned. So Dr. Gandhi is a professor of medicine and an associate chief in the division of HIV and infectious diseases at the University of California in San Francisco, and she's also the director of the UCSF Center for AIDS Research, the CFAR. And importantly, she's a medical director of the HIV clinic, the Ward 86, which is a very well-known clinic in the San Francisco General Hospital. She's a devoted and dedicated mentor to many trainees and a wonderful advocate and a caregiver for many patients. She's dedicated her life to working on research that's optimizing HIV treatment and prevention, kind of looking at the intersection of HIV and women, adherence to HIV and TB treatment, as well as kind of both oral as well as long-acting injectable antiretroviral therapy. So Monica, we're thrilled that you're able to join us. Thank you very much for everything that you can share about the healthy aging, healthy living with HIV and the Golden Compass program.
Okay, well, thank you so much for having me. I'm so sorry that I'm somehow unable to turn on my camera. I will absolutely do that as we go along, or try. Can you see my slides?
We can see you, and we can see you.
Oh,
there you are.
Oh, thank you. Okay, great,
Good to see you.
great. And can you see the slides as well?
Yes.
Okay, great. So yes, I do want to talk about aging, and it's really important to talk about the pathophysiology of aging and people living with HIV, the aging of the epidemic. I actually want to talk about some of the syndromes among people with HIV who are aging, and give you a model of a clinical care program that we have developed at Ward 86 to address this. And so, it was actually this particular study performed at Columbia University by Wafa El-Sadar back in 2012 that showed us that there is an inflammation that is associated with HIV that is above and beyond what people without HIV are living with, because this was a study that looked at off and on therapy, because the therapies were really hard to take, in the 2000s, versus keeping steadily on therapy, because we used to take people off and on therapy. It was called the SMART study. And it turns out that people who went off and on therapy had higher rates of inflammation. And that was manifested as increased rates of cardiovascular disease, kidney disease, liver disease. So just having untreated HIV led to an inflammatory state that essentially accelerated aging. And even with antiretroviral therapy, absolutely it decreases inflammation, but maybe doesn't take it away completely. It almost takes it away, but not completely. So there's ongoing immune activation with HIV, which means that aging can happen faster. And when
Monica,
we think about
can I interrupt you, Monica, for a second?
Yes,
do you mean to advance your slides?
I do, but they were not advancing.
They were not advancing, but
okay, then glad you told me. So let's try resharing and seeing if I can get it to be like advanced. So now you don't see the slides, right? So I'm going to share again and go to them. And then can you tell me if you can actually see me going up and down, advancing?
Hang on.
No,
you can't. It's just staying on one.
No, it's advanced.
It's advancing. Okay, so you see that. Does this say immune activation for you? What does the title of the slide look like to you?
It's a chart.
It's slide number 5, but I think it's you. I don't know. You are not advancing them. You have to be in presenter mode.
Okay, let's do this. I was in presenter mode, but let's stop sharing. Let's do it again. Team, our program isn't so much on Teams or UCSF. They're more. Okay.
Yeah.
Okay, so here I am. I'm sharing. And do you see it? Does it say immune activation?
It says immune activation.
Yep.
Okay, and then does this next slide show a series of pictures
Yes.
of weight gain, of cardiovascular?
Bingo.
Okay, I'm going to keep it off presenter mode then, actually. I'm going to keep it in this mode because this is the only way I seem to be able to advance. So I was in presenter mode before. So, okay, so this was really showing that that this immune activation still is ongoing, essentially, with antiretroviral therapy. And so the HIV epidemic is aging, and it's really from both new infections happening in older people, and older people, of course, with HIV living longer due to ART. And over 50% of people with HIV in the US are over 50 years old, 20% worldwide. And it's important to develop designated clinical programs for this group. And when we think of the geriatric syndromes, we have to worry about cardiovascular disease, about non-AIDS cancers, about bone thinning, osteoporosis, about weight gain, which can be associated with antiretroviral therapy, about diabetes and frailty, and cognitive disorders, chronic liver disease, and also kidney disease. So these are the concerns that we have about aging-related syndromes in people living with HIV. So what have we developed here in San Francisco? Well, we developed a program in 2017 called the Golden Compass Program. And the way that we did this is we first started with a community needs assessment. And it required a literature review. We started a pilot program called the Silver Project, and we did focus groups with patients and providers to ask, what would you want in your HIV aging program? What are the components that you want to lead up to this? And the community perspective was provided by both the focus groups, but also by long-term survivors, community forums here in the city, like Kicking Ass. We did a city needs assessment, survivor groups, and we also looked through the literature. And research in San Francisco and others had shown that frailty is a concern, hearing impairment, mobility, difficulties with activities of daily living, incontinence, falls. Those were the 6 highest syndromes. And then visual impairment, depression, cognitive impairment, and pre-frailty conditions and difficulties with activities of daily living. So we wanted to address all of these in our clinical program. Falls were actually, unfortunately, quite common, 40% in one geriatric assessment, being dependent on others for activities of daily living, and loneliness was also a big component. And people were concerned about polypharmacy. People were concerned about having too many medications, too many interacting medications. And so that was definitely a part of our program. And how did we put it all together? Well, we then did focus groups, and that was asking people, what would you want? What are the designated features? What do you want it to be called? Because we actually we had thought to call it the Silver Project, and actually people didn't like that. People living with HIV, at least in our focus groups, didn't like that name because it seemed colder, and the word golden seemed younger, actually. And so these were all the things that we thought of when we were putting together this program. And how did we finally put together this program? Well, this is the Golden Compass Program. And if you look at this, it's actually very much on 4 components of a compass. So we call it the Golden Compass Program because we are organizing it around the compass. And the north side that you can see is actually the we call heart and mind. And heart and mind is essentially the idea that we would have a cardiologist on site. We'd have cognitive programs on site. We actually have puzzles. We have brain narrative exercises. We have people tell their stories. We have people write their stories, and it's essentially having the heart and mind was so important. That is the north point of the program. What is the east point of the program? The east point of the program is that component of frailty, of geriatrics assessment, of bone health, of really basically at this point having a geriatrics on site. So we actually have a geriatrician that we've employed who is focusing on frailty and concerns of older individuals. She is there every week to help people with HIV. What is the southern point? The southern point is the social programming, is having social interactions. We have groups, we had walks during the pandemic, we now have social groups that meet once a week. And we also talk about estate planning, we talk about DPOAs, other things that would be useful for people to know. And then what is the western point? That is navigating people to dental, hearing, and vision, because that was considered such an important part that came up in the focus groups. So in terms of having the cardiologists on site, a couple of things that we're adding to our northern point is adding an endocrinologist, because now we're getting into weight gain issues with antiretroviral therapy, which I'll talk about in a minute. And we have to think about GLP-1 agonists. And also we want to talk about osteoporosis with our endocrinologist. What we do always think of when we think about our programming is what are called the geriatric 5Ms. And this is a concept in geriatrics to concentrate on what the person in front of you needs the most. People are very focused, as they should be, on mind, on mentation, on dementia, on delirium, depression. We also are very interested in mobility and how to ensure that in the home or wherever people are, that there's an improvement in gait and balance. We're very interested in medications, and reducing the number of medications, so-called polypharmacy, multi-complexity, multi-morbidity, and also what matters most to someone, what matters most, so that we can concentrate on that for them. What's next for Golden Compass? As I said, we're interested in diabetes, weight gain, metabolic effects, and really pushing statins for our community. Weight gain is becoming a big issue in people living with HIV, and actually it's partially a result of the medications. It's actually the combination at this point of what's called tenofovir alafenamide and INSTIs that is leading to this concern about weight gain. This sort of data started in 2019, that we started seeing that with the increased use of with integrase inhibitors, that we're seeing quite increased rates of weight gain among people living with HIV. Okay, someone is trying to get my attention and I'm telling them no. And so essentially we have always been concerned. Weight gain was something that was a phenomenon that we used to see with protease inhibitors, but now this is really being associated with integrase inhibitors. Some of the first data that showed us when we look across the United States is that there's already an increase of weight gain and obesity epidemic here in the United States, of diabetes, of cardiovascular disease, and of obesity. But if you add on to that the antiretroviral therapies potentiating that, then we've been more concerned about weight gain in people living with HIV. Now, the prevalence is also rising worldwide of being overweight. And in NA Accord data, for example, 80% of the 3-year weight gain that's occurring with antiretroviral therapy is occurring in the first 12 months. And it seems to be more prevalent in white men and in non-white women. So what do we do about that weight gain? Well, this was one of the first studies that showed us that it was really the combination of integrase inhibitors and TAF. So many people are on that combination. For example, the commonly used Biktarvy here in the United States has a combination of an integration inhibitor, which is bictegravir, with tenofovir alafenamide, which is TAF. And this was the advanced study that was performed in South Africa that showed us that that combination of dolutegravir and TAF worked really well compared to efavirenz or dolutegravir and TDF. But on the second, here you can see on the bottom that that top line is the blue line. That is the combination of integrase inhibitors with TAF. And there is an increased weight in both men and women. And actually the weight was higher in women. The weight increase was higher in women in South Africa. Now, this has been shown in studies here in the United States that, again, what's more commonly used here in the US is bictegravir. And that combination of bictegravir put together with TAF, the brand name being Biktarvy, is more associated with weight gain than our older regimens. What can we do about it? It's part of our Golden Compass program. We have been considering switching people off that potentiation of that integrase inhibitor and TAF. This was a study called the Characterize study that looked at women in the advanced study that I just told you about who had gained weight on dolutegravir and TAF, and switching them back, taking that TAF away and putting them on something back on TDF. And there was actually some weight loss among the women. So we are thinking about changing antiretroviral therapy, but of course, GLP-1 agonists, exercise, food changes are really the mainstay of weight loss among people living with HIV or people without HIV. So in terms of those studies, exercise, nutrition, GLP-1 agonists are really our mainstay of how we try to help with weight gain on the antiretroviral therapies among older people. What about statins? This was the big study. This was, oh, sorry. Yes. I can hear you. Are you trying to tell me something? Oh, I'm sorry. I think someone was off mute. Okay. You still, Magda, you can still see my slides and hear me okay?
Yeah, sorry, I couldn't unmute myself. Yes, looks perfect. Thank you.
Okay, great. So what about statins? So the Reprieve study was the big study that was published in the New England Journal, and it looked at essentially randomizing more than 5,000 people living with HIV to either placebo, and they were all at low to moderate risk of cardiovascular disease, or a statin. And essentially it showed that being on a statin, even when there's a low to moderate risk of cardiovascular disease, was associated with a 35% reduction in major adverse cardiovascular events. Now, this really shows us that statins are important, that statins really can reduce that risk of heart attacks, of strokes. And what we're pushing this most for here in the United States is using it among people with HIV who are at moderate risk of cardiovascular disease. And that's really what changed for the Reprieve trial. We used to push statins for those with higher risk of cardiovascular disease, but now even at moderate risk, there is a benefit to statins, and we should be considering them very highly. The other thing to think about among people who are aging with HIV is bone disease. So the one thing at the beginning, I told you about the SMART study that said that you need to be on antiretroviral therapy sort of steadily. That's what's important to reduce the inflammatory state. But there was one organ in the body that didn't do great from having ongoing HIV therapy, and that is actually bone health, because some of our HIV medications actually are not, can lead to reduced bone health. This was most associated with tenofovir disoproxyl fumarate, or TDF, but even the current formulation of tenofovir, which is called TAF, or tenofovir alafenamide, can reduce bone density. And so it's very important to look at bone health among people who are older living with HIV. And these are the recommendations that are still in place, that any postmenopausal women should be screened regularly with DEXA scans living with HIV. And for men, an age of 50 or older should get regular screening by DEXA scans, which are a way to measure bone density to ensure that there's adequate bone density and health, because you can do something about it. You can use calcium, vitamin D, and even medications called bisphosphonates for bone health. What about PrEP in those who are older with HIV? Well, of course, older people have sex, and age is not a condom. And what do we do about pre-exposure prophylaxis? Well, I just told you that the compound that's in oral PrEP, which is either TDF or TAF, can have effect on bones. And we can't have effects on bones for people who are older living with HIV. So I would actually really encourage the use of long-acting modalities for pre-exposure prophylaxis in those who are older. Cabotegravir was approved in 2021, and that's every 8 weeks given as a prophylactic agent for PrEP. And lenacapavir was approved in just on June 18th, 2025. It's expensive. It hasn't been put on Medicaid formulary yet, which I'm worried about, but hopefully it will be. And lenacapavir is once every 6 months for pre-exposure prophylaxis. And I would be more interested in that for the long-acting modalities for people who are older than the tenofovir-containing projects. What about doxycycline? Well, doxycycline post-exposure prophylaxis is really what is useful for essentially preventing other STDs like gonorrhea, chlamydia, and syphilis. To be fair, there is decreasing susceptibility of gonorrhea to what are called tetracyclines, or what doxycyclines in that family. So it doesn't work as well for gonorrhea, but we're seeing very amazing effects in ecologic studies on syphilis rates and on chlamydia rates with the use of doxycycline post-exposure prophylaxis, which is just taking essentially the pill of doxycycline after the sexual event that could have led to the spread of an STD. And that needs to be encouraged in older people living with HIV. And then other things to be encouraged is HPV vaccine. Right now, HPV vaccine, or human papillomavirus, which is a virus that can lead to cervical cancer, tracheal cancer, anal cancer. These are vaccine preventable cancers, actually. And even though this is a vaccine series for children and adolescents, there are many adults who haven't been vaccinated for HPV. And I push that in my older people living with HIV. People are absolutely sexually active and should have that benefit of HPV vaccine even after the age of 45 years old. So in conclusion, absolutely the population of people with HIV in the world are aging. We need clinical care paradigms specifically focused on this group. We need to think about weight gain, metabolic effects. We need to think about too many medications that people are on, especially that they have to be on antiretroviral therapy at the same time. Control cardiovascular disease risk. Statins is a huge part of that. Work on exercise, frailty, and bone health. And social groups are incredibly important. Being socially connected. People lost people when HIV first started. We need that social interaction and that coming together as a community. And of course, pre-exposure prophylaxis should be used at any age, and STD prevention. And I'll stop there and take your questions and comments.
Wonderful. This was amazing, Monica. There's one question in the chat about from Jeff about the meningitis B vaccination,
Yes.
to provide partial protection against gonorrhea.
Yeah, it's a really good question, because there was a big hope from preliminary data in the IPRGay study that the meningitis B vaccine would actually provide protection against gonorrhea. I mean, they're both in the same family, actually. Gonorrhea and meningococcus are both what are called the Neisseria family. So we thought they'd have cross protection, but actually the later data set of IPRGay really showed that there was not protection against gonorrhea with the meningitis vaccine. And there is really only, because even doxycycline is not effective now, increasingly against gonorrhea, we really need a designated gonorrhea vaccine. And that is being developed. I mean, it's being developed by GSK, actually, but now we're in an era, and feel free to talk about this terrible era that we're in. We're now in an era of anti-vaccine sentiment, of leaders in the Department of Health and Human Services not pushing vaccines, of not great investment of the NIH, for example, in vaccine research. And I'm very concerned that there will be slowdowns, actually, of that vaccine platform and the gonococcal vaccine coming out because of our current state that we're in.
Yeah. Yeah, no, these are terrible times indeed.
It's a
Before we got
terrible time.
Lorenzo, you had your hand up, and then I'll moderate the other questions. Yeah, but Lorenzo, the question. Were you speaking, Lorenzo? You're on.
Yes. What about
Okay,
older
perfect.
adults that have persistent that are on ART and that has persistent viremia? Are they infectious, or how does that work? I mean, how are they managing that?
Yeah, I mean, there used to be a time in HIV medicine where we just didn't have great drugs and we, quote, tolerated, ongoing viremia, even low grade viremia. This is no longer the case. Really, we have such effective HIV medications that our hope is to get everyone virologically suppressed on antiretroviral therapy. But what does that number mean? That number actually means less than 200 copies per mil of the virus in the bloodstream. So, right now the CDC guidelines, when they actually say the percentage of virologically suppressed individuals around the world, around the country, they actually are using a cutoff of less than 200 copies per mil. And so having 130, 150, that's okay. But no, actually above 200 is problematic for two reasons. One is the health of the individual. There's been shown that ongoing viremia, even low grade, leads to, again, in those increased inflammatory syndromes, which is not desirable to have those increased inflammatory syndromes. The second is that the U equals U data, the undetectable equals untransmittable data, really shows that it is that 200 copy per mil mark that can lead to forward transmission to others. And if you keep a viral load that's less than 200 copies per mil, then undetectable really is untransmittable.
And I have a follow-up. Have you heard about the parties in San Francisco where they are having sexual parties and then they're giving diclocycline as when you exit the party?
I mean, that to me seems like a good idea because, again, it is very effective for prevention of STDs, chlamydia, and syphilis. So giving that doxycycline, just having that right there. The only issue is gonorrhea, and really sad to say that we're increasingly getting that gonorrheal resistance to doxycycline.
Yeah, yeah. And Nels was commenting that they've encountered that. Jeff, I'll get back to you in a minute. Let me take a question from Orbit. Orbit, you were asking about HPV vaccines, is that right? And how and guidance around that. And you were, Monica, you were kind of referring to the older age groups and insurance company reimbursements for that. That's probably, sort of challenging as well. I wonder what your experience is with that.
Okay. So this is a very good question because the reason that people have been so worried about the dismissal of the entire advisory committee of immunization practices by the HHS Secretary, RFK Jr., ACIP. This was a long-standing, very qualified committee to make recommendations to the CDC about what to put as our vaccine immunization schedule here in the US. And on June 9th, there was the shocking dismissal of all ACIP members and an installation of a handpicked group of 8 individuals, some of whom have been very vaccine skeptical. Now, why does that matter? Because if vaccine recommendations change in this country, if the vaccine immunization schedule changes, insurance won't pay for it. Insurance can just look to the vaccine schedule and say, I don't see that HPV vaccine is on this schedule. And even now, it's only approved up to the age of 45 for those who had not received prior HPV vaccines as children. So I have to say I'm extremely worried about reimbursement of that. Right now, we still have the ability here in California to give HPV vaccine to our older patients. But I will say that we also have Medicaid expansion. We have undocumented immigrants who are on Medicaid through the state. And I'm also tremendously worried about the $1 trillion cut to Medicaid. So when you say awful times, I don't think that word even covers what we're going through. It is so difficult right now. And that's all I can say. You know, I would definitely write something for the insurance company to say why I think this, my patient needs HPV vaccine, and then hope that they would cover it.
Mm-hmm. Yeah. I totally know what you mean, and I've encountered those issues as well for my patients.
Yes.
Jeff, did you had your hand raised?
Yeah,
Jeff
thank
Taylor.
you. And we were discussing this before you came on, but this is all great. And those of us, working on the ground and living with HIV, this is kind of old news. It's important, but we've been living with this for a while. And the model you have is amazing. My question is, how do you fund this, and how reproducible is that in other jurisdictions? I know in San Francisco and New York, you've got city fundings. In smaller cities, I'm in Palm Springs, which is where all your housing crisis refugees from San Francisco end up. And we don't have those
Yes.
resources. So
so
we've got
true.
a lot of people who could benefit from this and can't access it.
It's a really good question, because actually a lot of it comes on we could do on insurance and Ryan White. So, and by the way, like, if there's any glimmer of hope in all of this, like Ryan White Part A and B that's the one thing they seem to have not noticed or cut in the proposed White House budget. And Ryan White A and B actually does fund the bulk of the Ryan White care programs at most clinics. There is a couple of things that look like they're could be cut. The women's specific program F, dental care through Ryan White, and also the White House proposed HOPWA being cut, which is housing for people living with HIV. So I'm very disturbed by all that, but was at least happy about Ryan White care Part A and B. In terms of how we fund it, we have been using current insurance, for example, for bone scans, for the geriatrician, for the cardiologist on site. But there are some things that we can't use insurance for. We have what's called a brain health expert who comes and does those kind of complicated narratives, or how you challenge your mind, puzzles, and having people write their narratives, their stories. That is brain plasticity. It's increasing brain health, and that we have to actually pay for. And you're absolutely right that in the city of San Francisco, because of it being the epicenter of the epidemic for so long, we have traditionally really enjoyed clinical support for our clinical programs from the city. The city, after the pandemic, is now $1 billion in debt. So I don't know if we're going to keep on getting that. But so far, you're right. We have supplemented the Golden Compass program through city funding above and beyond health insurance. And we've been lucky in that way. We have also appealed to Gilead. We have a grant from Gilead that supports HIV and aging. So they put out these, investigational grants, and we always apply for them. ViiV has been less generous than Gilead. I have to say it's easier to get funding from Gilead than I've seen from ViiV. And then we also have tried through the Levi's Foundation, didn't get it. Elton John Foundation actually didn't get it. MAC Cosmetics didn't get it. So we're always trying to fundraise for our HIV and aging program. And yes, we're not in a great time for fundraising either. And actually, I just saw that I think Mark Hubbard says something in the chat. So yes, including the withholding, of course. Yes, withholding of grants to major universities, absolutely. What is happening at the NIH absolutely does directly impact clinical care as well. I agree.
Yeah. Mark, thank you for your comment about what's not helping is sort of cuts to kind of university funding. David Martin, you had your hand up.
Yes, thank you. Can you hear me okay?
Yes.
Hi.
We can hear you.
Thank you so much for this presentation, and Lorenzo for inviting me. I'm the community co-chair for the HIV Health and Human Services Planning Council of New York, which is Part A, Ryan White. And so I thank Monica and your work for Golden Compass because we've used it as a resource and referenced in the Consumers Committee's led aging directive for New York City. And it's went on to the integrated plan for New York State. One of the things that comes up for me is the part about the aging, and we're focused on persons over 50 or 50 and over. And then what leads me to believe that maybe we're not taking into consideration the HIV accelerated aging and looking at lifetimers, those who, were diagnosed at birth. And my question is, how do you look at, or would you recommend earlier diagnosis or not diagnosis, testing, bone density test for those before age 50 or for those who are lifetimers, because some of them have HIV as long as, well, as of July 5th, I've been 38 years with HIV. And this morning also, I went for a bone density test, which is actually had to sign something saying that Medicare doesn't cover it. And just in case my secondary doesn't cover it, I would have to pay for it, which is one of the reasons why I think people aren't getting this test as much as possible, because they may have to incur the cost. So it's a lot going on there. But first question about lifetimers, how do you manage the fact that my condition is not covered for bone density test from insurance and HIV accelerated aging?
I do agree with you on the earlier bone density testing, not just at 50 for men, if depending on the duration of infection. Like you said, 38 years, I really would be very kind of pushing for it earlier. I will say that one of the patients I love the most, she was an older woman, and I do believe that her osteoporosis accelerated mortality in this patient because she had so many fragility fractures, and it was long-standing TD. She was very thin, and that also doesn't help. The other risk factors for bone disease or being very thin are having smoking, of having sort of family history, and also not doing weight bearing. Weight bearing is very helpful. So I always think about her and how I wish that we would have started even earlier than postmenopausal in terms of screening. So one can be very creative when they push for insurance companies. And I always write family history of osteoporosis, familial history. I will write whatever it takes, for an insurance company to approve early screening. And that's probably the best way to get around it, is familial history, because they can't argue that. They're not going to go and search in people's records. So that's what I would do as a physician to get it earlier.
And for lifetimers, for those who are younger, because their age just doesn't, trigger a bone density test. People are
no, that's what I'm
30s and
saying.
40s.
I would say even 30s and 40s, I would say familial history on my writing to the insurance company. And that's the way to get it, because there's an indication for earlier screening if there was familial osteoporosis.
Okay. Could you use HIV accelerated aging but I don't hear a lot about that.
I mean, there's no doubt that there's HIV accelerated aging, and I would use whatever it takes, essentially. And I would put both on your insurance form. I don't know what you do there in New York, but that's what I would do to push it, because there are just ways to, yes, there's insurance, and then there's ways that you write for insurance. For example, the Medicaid cuts, which we're all tremendously worried about. 40% of people living with HIV in this country are on Medicaid. 100% of people with HIV in my clinic are on Medicaid. we're already trying to brainstorm about how we're going to be creative, about disabling HIV. You have to have someone who's disabled, be on Medicaid, and how we will be creative about putting in the status of our people living with HIV to ensure that they stay on Medicaid.
Okay. Thank you. Again, thanks so much for your work in Golden Compass. It's been a blessing to have.
Thank you so much.
Yeah. And David, thanks also for your work on the, New York City, the DOH, kind of the HIV Planning Council. That's also incredibly important. So thank you for that.
We're trying our best. Thank you.
Yeah. Yeah. And as speaking sort of kind of advocacy and being involved, Orbit had a question earlier about just going back a little bit to the issue of the vaccines, Monica, that you were raising, how we're all sort of, terribly concerned about what's happening nationally in terms of guidance, and what can the community do? What can we do to advocate, make community voices heard in terms of kind of access to vaccines and coverage of vaccines by insurance companies and by kind of providers and recommendations? Any suggestions there?
Yeah, I mean, we are a noisy and active and community, and we have to do it. We got to go back to ACT UP sort of programming. We can't, I was in Washington, D.C. last week, and I thought about Jesse Helms' house being wrapped in a condom. Like we got to go back to our advocacy. We are advocating, but we need to band together, and we need to advocate, and we need to make lots and lots of noise. It is a very difficult time, and it's very wrong. It was such a pleasure to talk to all of you. And thank you so much for the invitation. And I just wanted one more apology that I was late this morning.
No worries. We loved having you, and actually kind of, sort of these cross-continental, cross the world sort of webinars actually really important when we talk about connecting and for people to get the information and then be able to speak out and have their voices heard. I think it's really important. So thank you, Monica. Thank you.
Thank you all so much. Appreciate it. Okay, bye.
Wonderful. Very informative. Wonderful. And I know that Jorge was recording the meeting, so he'll make the recording available for those who missed it, or maybe were only able to join us for part of it. So thank you again for all your wonderful questions, and for everyone who's been able to join us. I'll turn it over back to you, Lorenzo, and to Jorge.
I just wanted to say that for those who've asked about the slides, Monica will make those slides available. So don't worry, we'll make sure you get them. Thank you. And thank you all.
Thank you. Thank you for joining us. And I think someone was asking us, how do we stay connected? I know that Jorge can send around information about sort of, at least for our, many of us are connected kind of through our community advisory boards and research units. So that's sort of an important link. And I know that Jorge can share that information. It's wonderful. Excellent. Thank you, everyone, again, and enjoy the rest of your afternoon if you're outside of US, and the rest of your day for those who are on this coast.
Thank you so much.
Thank you. Bye.
Thank you, everyone.
Thank you.